Jonathon Feit. Kind of disappointed because coming after Amanda and Dr. Chen, that sucks. I mean, I should have gone first and set the bar pretty low. So thanks to you and Chi for that. So how many, I'm going to start with this because someone told me to be funny. How many of you have seen Old School? Will Ferrell. So if I pass out fully awake while giving this talk and what I say is brilliant, I don't deserve any credit for it. I'm going to wake up at the end. But I run a company called Beyond Lucid Technologies, and I am going to hopefully blow your mind with some of the discussion of what you probably don't think about when it comes to this, not only the conversation of quantity versus quality care, and I think in a nicely segue from the previous two talks, but perhaps things that you don't think about in terms of healthcare at all. So with that, just a real brief, my company develops software to connect ambulances and hospitals. And the next phase of our business is connecting vehicles with ambulances after a crash. So think an OnStar 2.0 type solution. And today, our work is focused on ensuring that people, essentially an emergency department, has some idea who you are when they arrive at the hospital, because that's not the case now. So the reason why I mentioned, I think it's an interesting segue coming off the topic. By the way, can you guys all hear me? Coming off the topic of quality of care and who is impacted by the conversation of quality of care is how many of you in this room think about emergency services on a regular basis? Okay, if we're like 6, great. You may have noticed, or you may not have noticed, but I did because this is what I do all day, that emergency services wasn't one of the items on any of the lists presented earlier today. With the exception, Amanda, thank you for putting us in the auxiliary box. We prefer being in the other box. But it's actually a really interesting and important point when it comes to this conversation. And I've been in this business now 8 years. And I only learned this fact probably about a year ago from someone who deals with this conversation around quality versus quality in emergency services every day. And it was, why is E.M.S., and by E.M.S. we mean ambulances, fire services, other types of both what we call pre-hospital care. That's what you see here on the slide. But the interesting thing being pre-hospital is also post-hospital, and we can talk about that in a minute. That is rarely part of the healthcare conversation because in the United States, it's not part of the healthcare system. In fact, ambulance services are considered a supplier to the hospital system, not a part of the healthcare system. They bring the patient to the care facility. And for that reason, organizations as diverse and as broad-based as the California Healthcare Foundation are not allowed by charter to fund emergency service-oriented programs. So when my company received money from the California Healthcare Foundation, it's because we were helping cities and we were helping hospitals deal with their ambulance patients as opposed to actually working with the E.M.S. services. So think about that. We talk about the idea that, say someone has a cardiac condition or they've had a stroke, they've gone home, they're being taken care of, they have COPD, and yet they want to walk around their house smoking. I have a friend who does that. It's kind of amazing. And at the end of the day, at some point, he may fall down because he's short of breath and hit his head on the floor, and all of a sudden there's a trauma, and someone calls 911, and the person who's showing up, by the way, Amanda, note, I didn't say he calls 911. Totally different conversation. You got it. Inside joke, y'all don't need to know. But the idea that he calls an ambulance who literally saves his life and takes him to the place where he's going to receive care. Full stop. That's really weird. So what I'm going to talk about here, some things that you already know, and hopefully are going to blow your mind in the process. The thing that you already know is emergency department utilization is rising. I tried to find some recent quote statistics on this subject to emphasize that this is still happening. So we're in the era of the ACA. I'm on record now. I'll be on record as saying I don't think the ACA is particularly going anywhere. So I'll either be right or be wrong, and everybody in this room can call me something when we're done. But the idea that, you know, as recently as 2 years ago, the busiest emergency departments in the country reported nearly a 1/5% increase, and even last year 12%. I mean, you're talking about large numbers that haven't really budged very much. And so this conversation is still very much ongoing. And the interesting fact about this that, again, a lot of people don't talk about when you talk about readmissions is what percentage of that readmissions is by truck, right? So there's a lot of people. In fact, in California, I forget the exact statistic, but it was something like, I swear to God, this is terrifying, 50% or so of heart attack patients drive themselves to the hospital. Okay, first of all, really bad idea. Second of all, really bad idea. Third of all, that means 50% of those people who are, we talk about how many patients have cardiac conditions and stroke and COPD and fall risk and diabetes and so on and so forth, and they come in and out of the hospital, and they typically do it by vehicle, right? And that vehicle often has a siren on, siren and lights and so on and so forth, and this happens a lot, and yet we don't talk about it in the context of care. And so as the emergency department systems are being overused and used more and more, they are being fed by these providers, right? So the next question becomes, well, who's using them? And this is where a lot of the conversation around the underserved and the underinsured really come into play, because the statistics are compelling in their skew towards the bottom end of the socioeconomic spectrum. So primarily 4 groups that comprise, and I'm going to get into much more detail in the next slide on this, but 4 groups in general comprise the bulk of emergency service utilization in this country. Those are people without insurance, because you literally, this off the record, but on the record, you can actually get free care in this country by refusing to talk to an emergency service provider when they come to your house. You didn't hear that from me, but it's true, and it's a law that was passed under Ronald Reagan. We can get into that in a minute. The elderly, so people who don't have any other way of getting to the emergency department, folks or who are out in middle of nowhere, or et cetera, et cetera. So folks who don't necessarily have the access to the transportation that they like, people who are low income. Again, same reasons. They may not have an opportunity to get there. They may not have a doctor. They may not have insurance. They may not know they have insurance. Or worse, they do know they have insurance, and they know that they can get, but it may be expensive. For example, catastrophic plans that we hear so much about these days in the topic of reforming healthcare reform. And yet, if you don't want to have to pay for healthcare, go by ambulance. And the last is mental illness. And this one is actually really interesting and really troubling, because the inputs to the system from folks who are mentally ill are not necessarily clear, right? You don't necessarily know if the person who is calling 911 up to 300 times a year, which again I'll talk about in a minute, but took place in the city of Alameda right across the bay, is that person sick? Is that person needy? Is that person abusing the system? And how do you engage with that person? These are really important and complex conversations. So a little more statistical information around who is using the emergency service system. More of them than not are male, black, have certain clinical conditions such as asthma, which are recurrent and chronic but don't have a physician. Folks who are on many types of medications, and the reason why that's a problem is not just because they're on the many medications, but those medications have a nasty habit of interacting, which causes all sorts of other problems. And if you ask an elderly person who is hard of seeing which medicine they took 2 pills of this morning, and you get the green one, that's a problem, right? So you don't necessarily know what's going into the system. Similarly, substance abuse, so that's both intentional and unintentional, right? Lord knows I don't think I have to tell anybody in this room that we have an opioid epidemic in this country. But the folks that I work for are on the front lines of this all over the country, particularly in Appalachia and so on and so forth, but also in some of the richest neighborhoods in the United States. People with psychiatric disorders, again, how do you tell if somebody is having a psychiatric condition, or if somebody is, say, post-traumatic stress, or if they're under the influence of a particular substance, et cetera, et cetera. And the final one is homeless. And this one is really interesting. It goes to the conversation around the economics and the idea of coming in and out of the system and its abuse and so on, is that if you're homeless, you have roughly 8 times more likely to be a frequent user of emergency services. Now, this gets us, again, I wish that Dr. Chen was here, because I would love to get her take on this right now. But San Francisco has a couple homeless people. Some of you may have seen that. But it's a really interesting problem in terms of the function of a safety net, right? And as we improve the safety net and invite people to utilize it, what that does for the resources that are opened up for them, right? And how that impacts the ability of those resources to provide care for everybody, especially when people are clogging that system, in some cases who need it desperately, in other cases who may need to go to a methadone clinic. And in California, with rare exception, in fact, there's 12 programs around the state that are piloting this now, emergency medical services are allowed to do exactly 2 things for you, which is something most people don't know. They're allowed to take you to an emergency department, and they're allowed to leave you. And you have to authorize them to leave you in most cases. You can't be transported to a clinic. You can't be transported to a doctor's office. You can't be transported to your mom's house. You have to go to a hospital. because EMS is a transport entity. It's not a clinical entity under federal law. So this is a problem, and it's a complex one. So I mentioned Alameda. There are programs, 12 of them in the state right now, that have gone through an enormous amount of rigor to get approved. It's actually a 2-year approval process. The one that my company works with is in the city and county of Alameda, where they are looking to address 2 particular populations, those who are frequent users of emergency services. And by frequent, there's a particular definition I'll get to in a quick second, or you can see right there on the slide, I suppose, in the meantime, and those who have been discharged from the hospital for particular clinical conditions that have a high statistical likelihood of coming back. Things like CHF, COPD, stroke, diabetes, fall risk, and so on and so forth. Sepsis is a new one that's coming up. So there are essentially 3 tiers of users. There are frequent users, super users, and mega users. And the fact that there's a mega users category is a problem. Again, mostly because we don't know a whole lot about why they've gone into the system in the first place. So how do you help keep people out when you don't know why they're going in? Super users are folks who have, according to the county of Alameda, called for emergency service help via 911 20 to 50 times in a year. So let's take the top end of that. You're talking about people who have called statistically more than 4 times a month for emergency services, not because they want to talk to somebody, although that ends up being the case sometimes. They are calling the emergency service system, and oftentimes it is because they want to talk to somebody, and that's an interesting question. Right? If you are a lonely elderly person who has no one else in the world to take care of you, and all you want is to talk to the dispatcher because you don't know anyone else, or because you have a phobia, and this happens in Contra Costa County. There's a population of people who call 911 8 times a week. Unfortunately, it's not funny. It's actually tragic. And it's because these are not people who are ill. These are people who are sad. And when you talk to them, they call because they're scared. Because you see those ads on TV, I've fallen, I can't get up. That's real. Right? If you don't have somebody who's coming to you for 6 hours or longer if it's a holiday because Meals on Wheels isn't going to be there and they brought you 2 meals today, they won't be back for 2 days, how do you deal with these people? Right? What resources do we have? And when EMS is being underfunded or defunded in some cases, our own county, my county, Contra Costa County, failed a measure called Measure Q about 2-3 years ago that would have, with I believe a 75 per parcel tax, that would have kept 40% of our fire stations open. Forget the emergency services for a second. We're in a tinderbox of a state. 2 to 3 years ago, in the middle of a drought, and Contra Costa County, in all of its wisdom, failed a measure to keep 40% of our fire stations open. Oops. It's a problem. The last one, these mega users, again, you're talking about people who need to be cared for in some other way. So the EMS industry often talks about the fact that we did a really, really good job of training people to call 911 for help. Now we need to really do a really good job of teaching them not to do it so much. So as an example, this is a nationwide problem. I'm talking a lot about California because obviously we're here. But this problem is very much nationwide, in particular on these 2 main areas, readmissions and frequent use of EMS, both of which you've seen referenced in the earlier slides, but not in the context of the input to that system, which in many cases is the emergency services system. This is a short list. There are more of them. And unfortunately, they are entirely, well, with few exceptions, they are entirely unsustainable financially. Because in the United States, show of hands if you know how EMS are paid in this country. And by EMS in this case, I mean ambulance services for the most part. Anyone? Someone mentioned earlier by the minute, right? That the doctors charge by the minute. Any idea how ambulances are paid? No, but close. Who said? Someone say by the mile? By the mile. Very good. So they're basically the most expensive taxi rides you'll ever take. They are actually, to simplify, they're paid by the mile, cost adjusted, for geography, the severity of the patient, and the certification level of the provider. And it's a really long conversation as to sort of how we got to those qualifications, because there's an enormous amount of fraud that goes into the EMS service, partly because they have to find some way to pay themselves. But unlike the rest of the healthcare system, there are no reimbursement codes associated with the work that EMS do. So if they use bags of saline and medications and defibrillators and multiple people and so on and so forth, and they don't take you anywhere, they make $0. Because if you don't transport, you don't get paid. So if you have to, when you look at the incentives associated with keeping people out of the hospital, And you look at these as being the most severe patients in some cases who need help the most. And you send emergency workers to their house to keep them safe and healthy and check on them and keep them from coming to the ED. But you don't pay them. That's a problem. And that's happening nationwide right now. The safety net problem in emergency services is a $3 billion hole. So I mentioned EMTALA. EMTALA is a law that was signed under Ronald Reagan, which is ironic because we talk all about socialized medicine as being a nice liberal thing. It was signed by the champion of the conservative movement. I wrote an article about this, incidentally. If any of you wants to go find it, it's on our website, beyondlucid.com. But the Contra Costa Times published it. It's called the most powerful healthcare law you've never heard of. And you see this every time you go into the emergency department where there's a sign that says whether or not you can pay, you will receive care. That's what that is. So don't say anything and you get free healthcare. Again, I talked about the payment models and the cost differential. So this is a conversation probably longer than I have time for now. But why is it that E.M.S. providers, and this, by the way, these numbers are based on the Santa Rosa market, where the largest E.M.S. agency in the state is based, pays its medics about $12 to $14 an hour. It pays its accounts receivable staff $16.50. Home health nurses make nearly $80. By the way, that comes out to about $28,000, $29,000. We were talking about poverty, and you're talking about EMTs. So paramedics make more than that, but still not as much as home health nurses or even the lowest paid firefighter in the Santa Rosa area. So you have to ask these questions, right, about how those incentives are set up. And so the battle to shift this in California has been remarkably complicated. And I'll give you a hint, it's not for clinical reasons, because checking on somebody and making sure that they're taking their proper medication and that they can sit up straight and they can breathe today is not a particularly complicated clinical task. But it took 2 years to even get the right for EMS agencies in 12 areas around the state to send their patients to someplace other than an emergency department or to take care of them in their home. The staunchest opponent of this process was the California Nurses Association. Any idea why? Turf war. It's our jobs, right? If we get paid $82,000 a year for this job and you've just given it to somebody who makes $28,000 a year, well, that goes pretty quickly. So the CNA was a staunch opponent of this until they realized something. Now I'm going to skip over number 3. Well, number 3 only has to do with the idea that some places you have nurses and medics pairing together so that the medics can basically, in the manner as someone earlier mentioned earlier about CMMI, right, the idea that if you're paying for nursing care and you're not paying for EMS and the two come together, the nurses can actually bill and give a percentage to the medics. So folks are trying to find a way to make this work. But the interesting thing that got the nurses to back down was essentially when they realized that they don't want these patients. These patients are not good for nursing patients. They're violent in many cases. They're really complicated. They are on substance abuse problems. If you are a petite, highly educated, highly paid individual who wants to make sure that make sure that your regimen is being followed, probably not as inclined to walk into an environment where they could get stabbed. But it turns out that in places like Dallas, where my company is working, you have 6'3", really strapping men who could pretty much throw that person onto the floor if they needed to. They feel more comfortable going into that environment. So the nurses backed down, and they allowed the firefighters and EMS professionals who wanted to do this work to have out those patients. And that opened the door to really interesting collaborations, like the idea that nursing and EMS professionals, or in some cases, EMS professionals and police officers, collaborated, particularly around things like mental health and substance abuse. That's the next level, the next stage of the program in Dallas, is for narcotics and opiate abuse patients, that they're pairing EMS and firefighters with police officers to go into the equivalent there of Skid Row and make sure that these folks are taking the medications, the various medications following the regimens they're supposed to follow, and if something goes wrong, someone is there. And this political conversation is very much below the radar. So I'm going to skip over these real quickly, but what I think can't be mentioned too strongly is the importance of context in these conversations. And I've tried to mention that in a roundabout way a couple times here, but the idea that we take patients at their face value, particularly those that require the safety net, is the source of much of our problem. The Twitterization of a complex discussion, particularly when you have human factors here, is a really, really big problem. Right? So there's a white paper that I wrote which focused on creating these kind of alternate care programs, and you need to be able to document what it is that you're doing and why and to whom, and to track that over time. Because in San Francisco, in the belly of the technology beast today, if you have a veteran who is homeless, suffering from PTSD and on substances to deal with that, and they have a seizure on the street, they are transported to SF General, stabilized and released, and they have another seizure 2 days later. Today, in San Francisco, there is no way for that second crew to know that that person was in the ED 2 days earlier for the same thing. And that's a shame, let alone a technical problem in the heart of the technology world. So the idea that we can track this information over time yields results that are compelling. This happened right across the bay. 75% reduction in returns to the ED within 30 days, and more than 51% reduction in what they call familiar faces, the frequent use of E.M.S, by folks who very well could be cared for in other ways, but today don't have access to that. I'm going to skip over this with the exception of one point, and it's to mention that the documentation that we and others capture in order to be able to do this longitudinal information is not clinical information. It's access to food, access to clothing, safety, transportation, the use of tobacco. I did want to highlight that one of the benefits of capturing tobacco, alcohol, and substance abuse usage is that it's one of the only places where E.M.S actually maps onto value financially. Because if you can reduce somebody's use of cigarettes and drugs and alcohol, you can actually show a statistical improvement in health, a reduced likelihood that they come back to the emergency department over time, and they tend to get better. But the idea that, again, these non-clinicals are so critical that, and I'll end with this, there's a keystone story that the folks in Alameda like to tell of a woman who was calling 911 for services several times a month. She was in the super user group. And when they went out to investigate why, what was wrong with her, they didn't find anything. She wasn't sick. It turns out she was malnourished. So why wasn't she have access to food? She's poor. She had Medi-Cal, and she had qualified for food stamps. Why didn't she get them? Well, it turns out, in California, to get food stamps, you need an ID. And she didn't have any way to get to the DMV. So she was calling emergency services because she was sick, feeling unwell because she didn't have access to nutrition because she didn't have a ride. So E.M.S gave her a ride and helped her helped her fill out the form to get an ID. She called once the following year, and it was for something completely unrelated. And imagine the improvement that she's had in her life and the cost benefit that has to the city and the county that don't have to be checking on her several times a month now. So thank you very much. I know I've gone over, but I appreciate your help.